Welcome to the Leo Training Podcast with Joe DeLeo. You'll hear in-depth interviews and tips from world-class athletes, coaches, and industry-leading experts to help you train smarter and improve at what you love to do. Train smarter, get stronger, move better, race faster. Here's your host, Joe DeLeo.
Welcome back to episode 35 of the Leo Training Podcast. This week's guest is Dr. Jean Thornton. The topic we will be discussing for this interview is rib injuries in the sport of rowing. We will discuss the three major theories surrounding the cause of this injury, what you can do to mitigate and prevent them in the future, and how to rehab from them. Let me tell you a little bit more about Dr. Jean Thornton. Dr. Jean Thornton, MD, PhD, is an Olympic rower and world champion. She earned a PhD in sports and exercise medicine and then completed her MD to put her research into action and rethink healthcare delivery. Focusing on physical activity as both prevention and treatment of chronic disease, Jane has developed educational resources and medical curricula in Switzerland, Luxembourg, the UK, and Canada. She is also passionate about rowing injuries research and lectures on both topics extensively. Without further ado, let's roll to episode 35 of the Leo Training Podcast with Dr. Jean Thornton, Rib Injuries in the Sport of Rowing. Dr. Jean Thornton, welcome to the Leo Training Podcast. Thank you so much for taking the time this afternoon to come on the show.
Thank you for having me. It's a pleasure.
Yeah, I'm very excited. I think we have some wonderful material and topics to cover, specifically geared towards the rowing community. But before we launch into that, let's take a moment of time. Why don't you introduce yourself and provide a little bit of background so that the audience knows who you are?
Okay, so my name is Dr. Jean Thornton. I am a resident physician here in Canada, specializing in primary care and sports medicine. I myself have rowed for many years with the Canadian national team and also just with the provincial teams and that kind of thing. So I've had a lot of experience with rowing. I guess it's been almost 20 years or so, 10 years with the National Olympic team. And throughout, I developed a real interest in rowing injury research and also looking at specifically at the mechanisms behind why some of these injuries occur and how to best treat them. And so I have a PhD also in sport and exercise medicine, so looking at the positive effects of physical activity in terms of prevention and treatment of chronic disease.
Oh yeah, this is going to be a very exciting episode. So I know. When I had an earlier guest on, we talked about low back pain and low back injuries in rowing. That was a very popular episode. So I know the topic that we'll be focusing on with this one being rib injuries is going to be very important to a majority of the audience. So with that, why don't we kind of just provide a little bit of overview or background and try to touch on why rib injuries actually may happen for sweep rowers as well as scullers, in case there's any differences.
Yeah, absolutely. So I think the main thing is we started seeing more of an introduction in rib stress fractures in the early 90s. And prior to that, there was certainly they would happen, but there wasn't a lot of standardized data or published results looking at the incidence of it. And it seemed to be that a lot of people postulated that these rowing rib stress fractures would come on because of the introduction of the big blade. So it was actually a change in the oar design that people thought because of the increased load, we would see a lot more injuries, but particularly with rib stress fractures. And so I think that part of that came along that people kind of assumed that it would be the heavier load and the different rigging, even though it was going to be increasing performance, would have this side effect of increasing the injury rate with rib stress fractures. But since then, so that was back in 92 when the hatchet blade, the big blade, was introduced. And so we're still, 25 years later, still grappling with why rib stress fractures actually occur from a mechanistic standpoint. A lot of theories have been put out there, but and we seem to be refining year by year. But really, there is kind of a big question mark in terms of what the exact mechanisms are. And actually, it doesn't seem to be a huge difference between sculling and sweeping that we can tell. Not only that, but we still can't really tease out a difference between male and female, or even lightweight or heavyweight. So we have some data suggesting that there's probably increased incidence in lightweight rowers, but again, we still just need a lot more data to support that theory.
No, absolutely. So it sounds like we're, the rowing community is starting to take steps to really kind of try to figure out sort of some of the big causes for why this is happening and really look at an evidence-based approach. So, like you said, there's been a lot of theories, especially with the change in equipment in the early 90s. Is it potentially, is it because the way the athlete may be transferring or accepting force or load into their body, at the beginning of the catch and then the drive sequence of the rowing stroke?
Yeah, absolutely. And it's a great question because there's a few things at play here. One would be kind of muscle firing patterns, and that's what I'll get into a little bit more because there's three big theories about muscle firing patterns that are really kind of dividing the camps, but also kind of pointing the way towards where our research should be going. And then the second aspect of it, which I can talk to after that, is really looking at intrinsic factors. So things inherent to the rower, his or herself. So in terms of the idea of energy deficit and bone structure and training patterns, things like that. So I think kind of the first thing to start with is really looking at these muscle firing patterns. And so as we know with the rib cage generally operates as a closed unit. So when we think about, we're not really thinking about each rib moving independently, although some have thrown out that theory in terms of maybe there's an aspect of one rib that's a little bit out of place and that kind of thing, and all of the stresses are on that rib in particular. But in general, we still see the rib cage as a closed unit, and that actually there's so many stabilizing muscles and ligaments around each actual insertion point of the rib, so that we still actually view it as one big unit. But even so, there's kind of three theories that people have proposed. The earlier one was more looking at Serratus Anterior. So that's kind of the finger-like muscles that attach on the sides of the ribs. And in really defined athletes, you can kind of see those muscles just line up down the sides of the body. And the Serratus Anterior generally pulls the ribs up and out. So when they contract, there's that movement, but then also it's kind of balanced by what the oblique muscle, so externus abdominis, so the obliquus externus abdominis, and that tends to pull the ribs down and in. And so generally speaking, when you look at that from a theoretical model, we think, okay, well, that makes sense that if there's an imbalance between those two muscles, then maybe something is happening in terms of force transmission to the actual rib. Because when we think about rib stress fractures, and I should also say up front that we're starting to think more of rib stress injury, because it's not necessarily fractures that are always causing the symptoms and pain that we see. But we're basically trying to say, if these it's basically micro damage occurring to the bone after repetitive stress. And so potentially there may be some kind of imbalance between those two muscles. So biomechanical studies since then have really shown that the levels of neuromuscular activity for those two muscle groups don't actually reach the levels necessary to induce that kind of damage. So people are starting to move away from that theory of just the serratus anterior and obliques being the main causative factors. And also, again, it kind of depends on the rower, but Some people activate the serratus anterior at different points of the rowing stroke. So it's not to say that it doesn't play a role at all. It may in certain individuals, but generally speaking, that theory has kind of been sidelined a little bit. And the second theory is looking at just the oblique, those obliquus externus muscles, just in terms of at the end of the drive phase. So when we think about resisting layback, so when we have a layback, whether or not it's a lot in some cases or just a little bit, the obliques tend to resist that layback motion. And so also they can assist in kind of that forceful expiration of the breath at the end of the finish of the stroke. So when we look at that, the timing of the peak activity of the abdominal muscles in that aspect, it kind of lends more support to that theory, but it's still, most researchers would say that it still doesn't kind of reach that level of being able to incorporate the high enough peak forces to induce some damage. And so then thirdly, of course, I'm going to leave the kind of most important one to the last, at least the one that we think may be more at play. And this is looking at a lot of, Anders Winther is a PhD, he's a physiotherapist out of Denmark. And I really I rely a lot on his research in terms of for my understanding of how these forces are acting, because he studied a lot of, he did his PhD thesis on this subject and looking at the peak forces, handle forces on the stationary ergometer as well. And so what he found was looking at race pace ergometer rowing and a high intensity ergometer rowing, we see elite level athletes reaching 900 to 1,000 newtons of force just during that kind of that peak force at the catch. It's just after the catch where that kind of peak force comes on at the stationary ergometer. And that actual, those levels of forces can also activate mostly latissimus dorsi and trapezius muscles. So those two kind of co-contract to transfer the handle forces to the ribs, to the core. And so those forces seem to be high enough to be able to kind of cause these micro damages to occur. So they also actually looked at bending forces as well in a single rib, and it seemed to again be kind of related to force production at the ergometer handle. So even though we still don't know the answers, we're still kind of looking more towards this idea of trapezius and latissimus dorsi, that co-contraction and that kind of transferring forces from peak handles from the ergometer handle to the core in being explanatory for some of the things that we see in rib stress fracture and injury.
Wow. So that's really cool, because I didn't even realize that there was 3 theories out there. And this is a important subject for me, because this is an injury that I've personally experienced, as well as I'm sure a lot of the audience has. So this one hits pretty close to home for me. So two questions. The first one I wanted you to clarify. So when you were describing the obliques, are those just the external or the internal and external obliques?
So the ones that have been mostly studied are external. Yeah.
Okay.
Yeah, exactly.
Cool. And then the second question I had as a follow-up, as you got into the third theory, and you talked about the trapezius and then the latissimus dorsi, I was curious to know if one of the things that they're starting to look at is maybe, the role that the posterior subsystem may be playing. So that contralateral latissimus dorsi with the opposite glute across the thoracolumbar fascia. So that one of the things that I've noticed when I've worked with some of my clients is that, take example for usually a sweep rower, the inside leg will be very dominant, and they will have a much easier time in a single leg stance on that inside leg, but they'll also be able to generate more force across that posterior subsystem for that one side of the body compared to the other side. So I was wondering if that might be a potential factor as well.
Yeah, and I think that's a great thought. I have read things about that, but unfortunately, there's no. And again, I'm kind of limited to when we're writing these kind of papers and to really focus on the evidence. And unfortunately, there isn't a lot out there in this regard. So that has been postulated, but as far as I know, it's remains in kind of the anecdotal realm.
Okay.
It would be a really, really good an interesting paper to see the data on it, but I don't actually have any more information on that piece. But again, as you said, in kind of what you experienced, certainly that could play a role. They haven't yet been able to define, and again, this may be because of numbers, lack of numbers, but whether or not a sweep rower who has a rib stress fracture has it on one side as opposed to another. So there isn't kind of one dominant side if you're a port side rower to have them on, your outside.
Right.
The only thing that we know is that it's usually ribs 5 to 9, but mostly mostly kind of in that mid-axillary line, which is, basically the outer half, I would say, of the rib. So those tend to be where they occur. But we haven't yet been able to, and again, not because it may not be out there, but just because we don't have the numbers to say that or to be able to, definitively say, if you're a sweep rower, this is the side it will occur on, and this is where it'll occur. Or even if you're a sculler, which of those 4 or 5 ribs that you'll tend to see more of a rib stress fracture occur. So, great thought and great question, and I hope that we have more research on that aspect too.
Oh, cool. Thank you. Well, I volunteer myself. If you need a research specimen or a guinea pig to do some of this testing, I volunteer myself for that.
Great.
So another question I had is, in terms of the rib injuries, just this is my own kind of from observation working with individuals on the water and then in the gym. Have you or has Dr. Vinther seen any correlation between, breathing from the neck or the shoulders rather than diaphragmatically breathing as a potential cause because the individual isn't properly bracing or reflexively stabilizing through the core musculature?
Mm-hmm. Breathing is a really fascinating topic because in terms of even peak force production during the drive, but also from a protective standpoint from injury prevention. So and again, so much is out there in terms of kind of without the research, evidence backing it, but there's a lot that, people say of timing of breathing during the stroke and how much it matters and that kind of thing. What we do know is not so much related to rib stress fracture or injury, but more to do with shear forces on the spine. And so for that one, there was a really good a research paper put out several years ago by Manning and Voliantis, I believe, who really looked at breathing patterns of that they would breathing kind of that diaphragmatic breathing that you're speaking of, or really kind of even the Danish way of coaching, having had a Danish coach, of feeling kind of you feel full, your stomach, your belly almost kind of feels full at the catch would be the way that they describe it. So that huge inspiration at the right, just prior to the catch, seems to increase intra-abdominal pressure. Right. And so hence that kind of belly fatness feeling or look. But that actually seems to prevent. So it has two interesting effects, and one is to increase peak force, so at the catch, but at the same time actually decreasing the shear forces on the spine, meaning that it could exert a protective effect for things like disc herniation. We haven't really, to my knowledge, haven't seen anything in terms of that pattern of breathing as it relates to rib injury. So again, that could be something that could play a role. Oftentimes, there are times that rowers will have intercostal muscle spasm, for example. So that could be stress related or fatigue induced or very high intensity work where there's actually rowers struggle with breathing all of a sudden. It's really kind of a muscle spasm in between the ribs. I don't know if it's related to rib stress injury per se, But again, it may have to do with their pattern of breathing. So again, it may be something kind of over time if that inspiratory muscle pattern is protecting against maybe, but again, I'm just kind of I don't have any evidence to back what I'm saying, but certainly if it's protecting against shear forces in the back, maybe it's also having that protective effect on the ribs. On the other hand, as you say, it may, if there's too much pressure at the catch where you're already increasing the forces as looked upon at the stationary ergometer, then maybe, it's just kind of making things a little bit worse. I will say, though, interestingly, that there seems to be a protective effect once you switch the ergometer. So even though we don't yet know about the breathing pattern, what we do see is as soon as you go onto a dynamic ergometer, the actual pattern of force production changes. And it's been known in the kind of the biomechanical exercise physiology research that you can get the same forces over time, and actually some people will get better ergometer scores. Theoretically, they would, using a dynamic ergometer or even putting a stationary ergometer on slides. And it just changes the force curve. And when you change the force curve, that seems to, the force curve isn't quite as high and peaked at the catch as it is on the stationary one. But somehow the overall force curve remains the same, and that's why you see the same or better scores. But what it does is seem to be protective. The theory is that it's protective against rib stress injury in the sense of it takes away that high, those peak handle forces. So that, if we move, so maybe the breathing doesn't play as much of a role, but it may play a role in people that are on the stationary ergometer day after day.
Very cool. Yeah, I know the breathing is a big, like you said, it's a big topic, big hot button issue, so to speak, and it definitely it can come down to an efficiency standpoint. Just from,
exactly.
We'll get into later in terms of movement, but ideally as a human being, we want to be diaphragmatically breathing. Now, obviously, when we're in the last quarter of a 2K race and we're racing, neck and neck, bow ball to bow ball, flat out, the chances of us maintaining a diaphragmatic breathing pattern are probably going to be next to none because you're in such a heightened state of stress,
Yeah.
But yeah, that was wonderful. I was just very curious about that myself.
Mm-hmm.
So, kind of shifting gears. So that was really great overview of the different theories of why rib injuries may be happening. So can we talk a little bit more about preventative measures in terms of things that rowers could do potentially on a day-to-day basis, or awareness, or things that they should be thinking about, to limit or, as much as possible, minimize risk?
Yeah, it's a great thought. So the few things that we can do, and again, since we don't totally understand what's happening, in some again, it's hard to prevent. However, there are some things that are coming out in the literature that are really interesting that could very well play an important role in prevention. In terms of strengthening imbalances, that is one thought that has been all the way through. So again, if we understand what the imbalance is in the first place for a particular individual, for serratus anterior or trapezius or whatever it may be, then we can work on specific strengthening exercises with a resistance training coach or that kind of thing. One interesting thing that's gained a lot of attention recently is the idea that most injuries tend to be not so much training load related in terms of chronic training load, but actual acute changes in training load. So looking at changes in either volume or intensity that come on abruptly. And so it seems to be almost a vaccine against injury if you can maintain a chronic high training load. So before, the thought was, well, maybe we just have too high of a volume, and that's why we see overuse injuries. But if the training load is actually progressed, so that would be volume, intensity, time spent on the water, if that's progressed in a generally linear, incremental fashion, that actually seems to exert a protective effect. So when athletes are training at a high enough load, they're actually probably not getting as injured. What we do see, though, is that if there's changes in that, so you can think about in rowing for us more northernly folk, that we need to have off water training for a lot of months of the year. That transition point from erg to the water, or vice versa, is going to be a pivotal point where training load and volume is going to change, and then also type of training. But then also looking at race time. So if we're keeping a high load, if we're looking at a big shift or abrupt shift in training load because of a race season coming up, that kind of thing, that's actually where we kind of should signify a red flag for time that we could be seeing injury of any type. But on the flip side of that, if someone is to get injured, whether or not it's rib or back or knee or anything, if they take off too much time, that's actually putting them in an acute training load decrease. And then when they get back to training, there could be an added risk for re-injury or injury of another type. And so I really think that coaches and physiologists and people who are planning out a season or planning out changes for injured athletes, that kind of thing, really need to keep that in mind, that those actually play very, so that can be preventative if done right, to just maintain a certain training load and only add to that incrementally if need be, or just make a kind of balanced long-term changes. And I guess the other thing would be just in terms of intrinsic factors, which we haven't really touched upon yet, but just that idea of adequate energy intake. So for lightweight rowers, it can be, again, kind of addressing those issues if there's any deficiencies in and it depends on the country, but also the jurisdiction in terms of if we actually monitor vitamin D levels, for example. But if rowers have any kind of deficit in calcium or vitamin D, or not enough energy availability in general, then that's going to predispose them to risk and potentially for rib stress injury, just in terms of bone health. The same thing can be, and we can touch upon that again later if you'd like, but just that idea of something that we used to term as a female athlete triad, that was looking at the triad of disordered eating, amenorrhea, or loss of menstrual cycle, and then osteopenia, osteoporosis. So even though those three don't generally happen at the same time, the spectrum of not enough energy intake can lead to hormonal imbalances so that athletes will become amenorrheic, and then consequently, as a result of that, have lowered bone mineral density. In some cases, that's they're unable to get back if it's during that kind of bone building years of adolescence and early 20s. Just to say that if those so that female athlete triad now has been expanded to include males because they're also affected, and so now that kind of the new terminology that was coined by an IOC consensus statement a couple of years ago is called RED-S, and it stands for Relative Energy Deficiency in Sport. And that's kind of looking at all of the major factors that can happen when one doesn't have enough energy availability. And one of the big ones is bone health. So those can all be addressed because we know that those are all risk factors. Those can be addressed on the flip side in terms of preventative measures. But again, as we kind of find out more about rib stress injury, then we'll probably be able to target those a little bit better.
Wow. That's a ton of information right there.
Yeah, sorry.
No, that was great. No, it's just, there's so many like pearls you touched on there in terms of, I think things that we may not look at in terms of, cause and effect in terms of, the diet and the nutrition and making sure we're getting the proper vitamins and minerals in our diet. Because, when we're talking about athletes, whether it's at, high school or college or pre-elite or elite level, they're going to be training much higher volume and intensity than sort of your recreational or, average person. And so the demands placed on the body are that much higher, and therefore the fuel requirements for the body are going to be that much greater. And it's a great point that you made there about, you need to not only properly fuel your body, but, that loss in bone mineral density could predispose one for a higher risk of, a rib stress fracture. And then the other interesting point was the idea of the changes in the training, from chronic to acute. So one question I had when you were discussing that was, could that potentially, I guess some of the points, for example, during an annual or a calendar training season, would the biggest sort of points that coaches need to worry about are the ones where you're transitioning, like you said, from being on the water predominantly to indoors predominantly, and then, back from indoors to outdoors, because you're spending all your time either on the machine or in the boat, and then it's completely flipping. So the demands and the response that the body is undergoing is completely different than it was.
Yeah, and I think one thing that I would kind of caution coaches to in terms of the transition period is just that if the athlete, for example, in many communities in Canada, but not all, we are relegated to the ergometer for winter training and then make the switch completely to on water training. And I think that if the same program is taken from the ergometer, the thought to be a seamless transition right to on water training, then and as you say, that's true, that's a kind of a higher risk period for injury. Reason being is these kind of force curves that we talked about on stationary versus dynamic ergometers, that kind of thing. So the force curve changes again when you're on the water, and that can change relative to the boat size, to the skill level of the athletes, to the rigging that's in the boat. And so because of those factors, if you take the same program and then apply it to something where, again, you kind of have to retrain yourself a little bit each time, you have to be a little bit careful about watching for injuries. Having said that, another big aspect of it is really just changing the intensity too quickly or potentially leaving the volume as is and all of a sudden upping the intensity. And so one can think of, okay, well, we have this transitionary month of April, perhaps, that we're on the water, we're putting in more volume, and then all of a sudden we keep that volume, but now we're doing race pieces. And even that change, when you look at the kind of the total picture of how the intensity, how much recovery is built in, and then just the sheer volume of kilometers that you're getting on the water, or miles, I should say. I should remember my audience. That particular idea is the things that kind of need to be thought about. That if you're going to increase intensity to a certain degree, to maybe back off a little bit on volume and kind of play it by ear. Having said that, there are rowers. The majority of rowers can remain uninjured and through these different periods. And again, some of it may be genetic, some of it may be due to bone architecture of the actual rib itself and that kind of thing. And so some athletes are able to self-manage. And I think that's an important point to think about, that it's not, we're kind of not at the mercy, we don't have to be at the mercy of training load or transition periods or anything that along those lines. But there's certainly ways that we can position ourselves to be better protected, I think, against injury in general. And those would be some of the factors. Yeah,
absolutely. So two other questions I had. One is, I wrote an article earlier this winter for Row 2K on talking about the transition from the ergometer, the stationary ergometer, to the boat. And I had found I believe it was a paper that had been written for a thesis. And they looked at the range of motion that the rowers were going through on the ergometer versus the rowing shell. And what they found is that you needed the ability to move through a greater range of motion through the trunk and thoracic spine on the ergometer, and greater hip flexion and ankle dorsiflexion in the rowing shell. So they're completely, counterintuitive. So you go from that environment where you're predominantly in a boat, and you have good hip mobility, and then you're going to spend 3 months on a erg 5-6 days a week, or even say you cross train, you're on a bike, and you're not accessing that range of motion going through full hip flexion. Is that potentially another marker that could contribute to injury right there?
Yeah, and it reminds me actually of there have been studies done looking at ergometer versus on-water training as well, but actually looking at the proportion of upper body versus lower body, and in terms of musculature and forces that are produced during each stroke. And when you make the switch to ergometer training, that's actually predominantly upper body. And, it kind of makes sense that there's some people on the team that will be great on the bench pull and all those kinds of things, and just massive, erg beasts or whatever. There's crazy scores that they can get. And it also may explain why people from other sports, from canoeing and kayak, for example, that can literally jump, even some CrossFit athletes or dragon boaters that use the ergometer for cross training, and they can jump on their rowing machine and just produce these incredible scores that some rowers would never be able to touch. But then you put people on the water, and of course there's a whole other host of factors for people that have never rowed before from technique standpoints. But the idea that the lower body, so using our legs, is much more predominantly seen in on-water rowing. So again, whether or not it's, as you say, kind of the hip flexion idea, that kind of range of motion idea, because some people actually will get increased extension. So when you think about the layback, some people can really exaggerate that on the ergometer as well. So it's really that kind of full range of motion, and you can see a lot more exaggerated reach to the catch, kind of hitting the cage at the front end or something like that. So, but it does seem to be more predominantly an upper body exercise, and so that may explain some of although we don't have enough data, and again, this is a kind of like the call for data I feel like I'm making through this whole thing, is that if we could have more studies done on this to look at the incidence of rib stress fractures on each type of ergometer and then on the water, again, we really need more numbers, and probably looking at something worldwide or multi-center to try to figure out if there's a statistically significant difference between all of those. So there could be some people, for example, that just don't have that volume of erg training, that they never get to that point where it would cause a rib stress fracture, or maybe they injure another part before it comes to that point. So, perhaps a disc or something like that. So really good points. Cool.
So one question I had. Sorry, I keep getting questions as you're describing stuff, because it's very rich information. So has there been any studies where they've had like EMG hooked up to a rower on the ergometer, for example, where they're measuring the muscle activity during the rowing stroke? And my question is, have they caught an injury during a study? So while the person's rowing, has there been an incident where they've had a rib injury or even a low back injury where they've potentially caught the data points, so to speak, if there's been a change in muscle activity?
Wouldn't that be great? I mean, not for the rower.
Right.
Would that be interesting from a research point? To my knowledge, no, that hasn't happened. They have done quite a few EMG studies to look at people, which I can certainly send you if you want to post or something like that. But there's EMG studies looking at muscle firing patterns and, who's more and then kind of follow those rowers to see who gets injured and who doesn't. Again, there's a couple of small studies, but there's been a couple done by Canadian researcher Courtney Pollock, who's a physiotherapist, and I think she actually worked alongside Dr. Vinther, or had him on the paper. So that would be, and also worked with Dr. Volker Nolte, who's one of the Canadian coaches, but he's of German origin. So he did his PhD in Germany and came over to Canada and has studied a lot of this kind of biomechanical, these issues. So so yes, that would be great to be able to see what is actually happening. With rib stress fractures, it's really hard to gauge a particular point at which that becomes an actual stress fracture, because it's a lot of micro damage over time. So there is that one point where an athlete can feel a sharp pain, and all of a sudden then they start feeling it when they're coughing or rolling over in bed and those kinds of things. But it's really hard to pinpoint exactly when that micro damage would have begun, because I think we would have to see it over time. Disc herniation may be easier to see, but to have that opportunity to catch something while it's actually occurring, I don't know if you couldn't even set up a study to look at that ethically.
I'll volunteer for that.
Sure.
I will come
this
in.
Is great.
I will personally put myself into the floor in terms of like just going hard because my interest is, the more like you talk about gathering the data and everything, the more we can learn about why it's happening, right? Like, because that's the thing. It's very difficult to come up with a truly effective evidence-based rehabilitative protocol if we can't determine the root cause, right?
Yeah, exactly.
So yeah, I mean, to me, that's worth it. I've had I'll never forget. I remember being in my kitchen once cooking breakfast, and I sneezed, and I felt the rib move in the rib cage, and it was like just being covered in broke out in a sweat, and like completely lost my breath, and doubled over, just trying to get through the wincing and the pain. So it's very real, sensitive subject and stuff, and I know it affects a lot of rowers. So it would be worth it to me to put something out there that's going to help the rowing community at large, long term.
Yeah. The unfortunate part of it too, though, is that because it's micro damage, and whether or not we can pinpoint it to a certain muscle or a certain biomechanical way that the rower is rowing or activating these muscles, we can see that over time. As you say, if someone's on a rowing machine for a while, it would have to be quite some time to be able to see that. But then whether or not that changes, do those muscle firing patterns change in that particular individual when they switch to the on-water rowing, for example? So again, what happens when the balance is off in rough water? And what happens if they switch from sweeping to sculling? Maybe one is particularly beneficial for a sweep rower. Some people say that sweep rower, and this is anecdotal evidence again, but that idea of a sweep rower switching sides, for example, to rehabilitate after a rib stress fracture or injury, and sometimes it works. But again, what are those things, and can we actually follow that over time? Because it's not, even though people will have rib stress injury that could actually, if not dealt with and the fracture occurs, there have been cases of elite rowers even puncturing a lung because of, a rib stress fracture gone haywire. So then it becomes an actual fracture. So again, those kinds of things, well, we may be able to pinpoint the kind of the onset, or when symptoms change enough to kind of really elucidate that pain that you're talking about, that painful wince that all of a sudden something's very wrong. It's hard to look at every single factor that's led up to that particular point.
Sure.
And there could be individual factors.
No, absolutely. Yeah. I mean, a lot of times it's very, very individual. One question I've had, and I've had a lot of athletes and coaches and myself, why is it when, and it doesn't necessarily have to be a rib stress fracture, but say it's just it could be the micro trauma, or maybe it's those intercostal muscles or spasming, but why do we get a sensation of pain behind the shoulder blade? Mm-hmm. Why are we feeling sort of referred pain in that area of the body instead of sort of local where the injury is actually occurring?
Yeah, so rowers will generally feel pain in different areas. So as the rib injury becomes more, goes on without treatment. So if the rib stress injury continues to happen, that over time it will become more localized. It's really just about the kind of where our nerve fibers lie along the rib, where pain is transmitted. Oftentimes, if it's still kind of a generalized pain, it could be still due to the spasming muscles around the actual rib instead of localized to the bone itself. So oftentimes it's referred pain from either muscle, that kind of spasming muscle, or oftentimes when it gets to the point where it's localized and someone can pinpoint and say this is where it hurts, then we actually know that that's a sign that it actually is a rib stress fracture. Beforehand, it could be in the development, and that's when we kind of think about it still along that spectrum of rib stress injury, where it could be a bunch of factors in terms of muscular still, or just kind of in the beginning stages. So it really has an idea. It's really based on pain fibers and where the nerve fibers travel along the rib.
Wow, very cool. Thank you. So kind of shifting gears, you talked a lot about overview and then sort of prevention. So what are, individual rowers starting to experience some symptoms. They have not fractured a rib yet. What are some rehab protocols or things that they should start doing? So obviously they're in sort of some level of pain, now. What should they be doing?
Yeah, so management of rib stress injury in and of itself hasn't actually changed much over the last 20 years. So it's usually conservative treatment. People talk a lot about, if to the point of, again, I guess we can talk about rib stress fracture first. So when they actually know that that's happened, we look at a period of approximately 3 to 6 weeks of kind of initial rest, and it's followed by kind of a gradual return to rowing, and it's really symptom dependent. And so that's depends on the athlete themselves, and basically, they'll do some cross training initially and that kind of thing. If it's very, very early on, sometimes it can be managed through maybe backing off training a little bit or changing it to another modality such as biking or that kind of thing. Massage, non-steroidal anti-inflammatory drugs. So that would be your ibuprofen or that kind of thing. But there's actually been a really good management algorithm that came out of the GB rowing team, and it's Guy Evans and Anne Redgrave, who are part of the medical team for their GB rowers, and they basically look at first of all, if you have chest wall pain as an athlete, there are different, what we would say in medicine is a differential diagnosis. So you could think about, it could be rib stress injury. It could be something called costochondritis, which is just inflammation along kind of the rib margin or where it kind of connects to the sternum. It could be muscle spasm or, kind of a soft tissue injury versus rib itself. But when you look at kind of clinical, so as a medical or healthcare professional, when an athlete comes to you for rib pain, then you would kind of elicit a history from them to really kind of tease out what it is. And with the rib stress fracture, it's more about this kind of either sudden onset out of nowhere, or it's kind of, they talk about crescendo pain over days and weeks. And then you have pain on deep breathing. So some of these things will probably strike a chord with you, having gone through it. Pain on pushing or pulling doors, difficulty rolling over in bed, unable to sleep on that side, and then kind of possible cough or sneeze pain.
Or laughing.
So, yes, yeah, there you go. Exactly. It is not funny to have that. And so it's, so what we would do is we would take that history and then we, do a physical examination. So then we kind of try to see if there's tenderness along those points of, what I mentioned before is kind of this mid-axillary line. So just kind of, if you draw a line from the armpit down, that's the axillary line when you think anatomically. And so you look from that line inwards a little bit, and you look at particularly those ribs 5 to 9. and look to see if there's any kind of swelling or tenderness over the affected area. If an athlete can point to where the injury is, that's usually a big marker. You can also kind of do a rib spring test or compression test where you kind of squeeze ribs and let go and see if that in and of itself is giving some pain. Anyway, so there's little things like that to first get a sense of what it is. And then from that point, this algorithm by Evans and Redgrave, which is quite helpful, looks at the severity of injury, and they grade it as if it's mild, moderate, or severe, and then do investigation. So if it's mild, you may not see anything. So oftentimes people could say, well, just get an X-ray. But rib stress fractures won't show up on X-ray initially. It may take up to 6 weeks. Some suggest doing bone scan. Then again, sorry.
Why is that? Why is there a delay in it showing up on an X-ray?
Yeah, because it's not, we can't see as definitively on X-ray if it's a stress fracture because it's that micro damage. Whereas you could see an actual fracture that would be fairly clear. What we end up seeing on X-ray actually 6 weeks later is more the callus that forms over the actual rib stress, the actual fracture point. So a bony callus can form, and all that means is that if you've ever injured any other part of your body, if you've broken something, sometimes it's kind of like bump will form where the bone had broken, and so basically because of through the healing process, new bone is deposited around that area, and it just forms a scar. And so it's actually what we're seeing on X-ray is the scar versus the actual micro damage itself. When you do something like a bone scan, it actually lights up where there's damage. So sometimes that can show, and maybe it's like an incidental finding. So if someone has damage but no symptoms, we would still see that on bone scan, but it usually highlights the spot. If there's a positive result, then we can see that that would be more indication of a rib stress fracture. And so those investigations are based on the kind of the mild to moderate severe, which I'm happy to also go through, but the management for that. So if it's early enough, then you kind of offload the rib, as I said. So it's really looking at stop kind of the rowing mechanics on the erg or on the water that are causing the pain. Initiate that kind of cross training cycling, or maybe move to a dynamic ergometer. But again, probably best to move away from rowing in the early goings if you can pick it up early enough to. And also some people consider they tape around the ribs so that a physiotherapist or athletic trainer would be able to tape to kind of offload that.
Are you talking about athletic tape or using a Kinesio tape?
Yeah, so either one. It depends on it depends really on. I mean, Kinesio tape would be probably what we would use more these days. Mm-hmm. In prior years, they have used athletic taping. Some people kind of question the proprioceptive. So sometimes we use taping almost to help proprioception for the athlete too, to kind of have an awareness of what's. So some people question the utility of athletic tape. So I would probably move towards the Kinesio tape, but I would actually say it's more dependent on the user in terms of the person who's actually taping. So if I taped, for me, if you put a specialized physiotherapist versus me, I would trust that physiotherapist because they're an expert in what they're doing. And so the people that actually have a lot more experience in that field, I would say that it's more dependent on the person doing the taping versus the properties of the tape itself in many respects. Although, yeah. You would probably have more information on that than I do, actually. So,
well, I work with rock tape. I went and attended a rock tape certification, which is a type of Kinesio tape, and I've used that with some athletes. And I've had both. I've had people stand up, and it's completely made a big change in the nervous system afterwards.
Okay. Yeah.
And then others, and they don't feel anything. And sometimes it takes till the next day when they wake up from sleep and they feel a big change, and some don't feel anything at all. So I totally agree. I think it's making sure you're, evaluating and assessing correctly, and then taping in the appropriate area that really needs it. So you have to kind of need the trained eye.
Yes, exactly.
Yeah. No, go ahead.
Yeah.
Thank you.
Yeah. No. That's what I was going to say. That the trained eye certainly helps in this respect. And then just to go through the final parts of management. So some people talk about ultrasound and laser treatment, and we haven't found a lot of evidence yet to suggest that's helpful, but some people would still suggest it in terms of kind of breaking up scar tissue or that kind of thing, or just trying to help with bone healing. And then really look at kind of gradual return to activity. And really, no matter how you treat an athlete, so that's really kind of the early part. I can talk to you about the severe, once it's kind of full blown rib stress fracture, we've got to deal with a big problem now. But just to in either stage, in whatever you're looking at in terms of treatment, the point is to only resume training to that degree when all clinical markers are back to normal. So those are the things that I mentioned about pain during rolling over in bed, or all those kinds of things. Once those are gone, then we can resume training. So we generally manage rib stress fractures that way. If it's really, really bad, then you want, the algorithm that is put out by the GB rowing team would say this, and I would almost say that this could be done anyway, but they would look at kind of assessing rowing technique and reducing areas of overload, which I would say probably in any point, that would probably be a good idea to help manage injury. But also looking at all risk factors, so intrinsic and extrinsic. So what we mentioned before. So is it extrinsic problem? Is it something with the boat, the rigging, the load on the ergometer, maybe the drag factor, or is it intrinsic? So is it maybe kind of a rower who has maybe a female lightweight rower who just switched to sweep, and she's been calorie deficient for a while, or energy deficient is a better way of saying it. Maybe she has some intrinsic factors that we can address first, and during that rehabilitation stage. So those are the kinds of things. But generally speaking, the only thing we can do if it's really to that point of bad rib stress fracture, that person's off the water for up to 6 weeks, and they're doing something else other than rowing.
No, that's fantastic. So one question I have for you, because I know you take a movement approach, to things. So what about, say you are evaluating it's in the severe stage, and you're watching an athlete, and you notice that when they're rowing, that instead of rotating through the thoracic spine, they're actually laterally bending through the thoracic spine while they're moving through the recovery phase. I'm not saying that is, the cause, but could that potentially be something that contributes, like the way that they're moving their body? It might be a compensatory behavior because there's pain there.
Yeah. And I think that, again, anything I would say about that, I see absolutely what you're saying. I can't back up by any research that I've seen regarding that, other than the only thing is that we know that they have to have a certain peak amount of amount of force high enough to induce injury. So again, it doesn't need to be, it could be small, just bits of peak force that's over time that's creating an injury, or it could be abrupt changes as well. So there are those two parts to it. So during the recovery, though, we don't see a lot of muscle activity that would kind of induce those forces high enough to cause micro damage. So and that's, I think, why they started thinking more about the load during the drive and that kind of thing. It's not outside the realm of possibility, but I think one of the big things that you've highlighted is that it's really about compensating for some other weakness, imbalance, or even if it's a change on the water. So compensating for a pair partner's balance, or their movement patterns, and maybe you're just trying to get the boat off starboard or something like that, and you're leaning a certain way, or maybe you've just that's the way that you've learned to kind of most efficiently row, or that kind of thing. The one thing too that I would say that we haven't really discussed, but certainly comes into play with back injury in rowing is that idea of over time, especially during race pieces, is fatigue and what fatigue will do to posture, and that tendency to actually either overextend over in terms of the layback, or actually reach forward and not have the proper technique or proper posture at the catch. And so the actual posture and firing patterns change over the course of a 2K race, particularly on the ergometer when looking at the back specifically. So that hasn't been studied, to my knowledge, for ribs in particular, but that could obviously play a role. And as you say, if you're leaning one side or another, as you're fatiguing or as you're doing high intensity pieces, that effect will be compounded.
Cool. No, yeah, that's exactly what I was wondering. So thank you very much. That was wonderful.
Okay.
Cool. So is there anything else that you want to leave the audience with regarding ribs before we kind of move completely away from that topic?
Yeah, I think that for anyone that's thinking that they are, maybe there's someone predisposed to rib stress fracture, or there's someone who's experienced repetitive stress fracture in the past, or is maybe at that stage where they're just starting to have some pain. And some people are not in the position where they can change the training plan. Maybe they're in the middle of selection, or they're getting ready to go away to college for a rowing program and that kind of thing, and wondering maybe what to do to prevent or change things up a little bit to mitigate any damage. Just a couple practical things I would say is to kind of look at the volume and intensity and of whatever training program you're following, and try to adapt as you can. So maybe it means that you don't have to, you have to do those race pieces, but maybe adapting the volume a little bit. For people who are on the stationary ergometer who find they have stress fractures during the winter season or whatever, talking to their coach, or just on their own, switching, either putting that erg on slides or switching to a dynamic ergometer and trying to see if that maybe helps things a little bit or protects them a little bit more. Analyzing themselves, their technique in through video or through the use of mirrors if they're inside, little things like that. And then also, if as a lightweight rower, but even some heavyweight rowers who look at your energy levels in terms of intake and output. So if you're experiencing an energy deficiency, if you're losing weight, granted, lightweights will maybe have to get ready for their season or race, but looking at maintaining adequate calcium levels and vitamin D, getting that tested if you can, if that's an issue for you. I know a lot of us medical professionals in Canada, because of our healthcare system, we're actually trying to decrease the number of vitamin D blood tests we do. But in certain cases, if someone's a lightweight rower who has experienced rib stress fractures, that kind of thing, maybe it's something to bring up with your physician to see if you can get those levels tested. So you're doing everything possible that you can to get yourself in a good position to do that. And the last interesting thing I'll say, just in terms of para rowers, so it's another whole class of these Paralympic class rowers that now we're seeing injuries. There have been case reports of para rowers actually getting rib stress fractures due to just the chest strap that's used to while they're rowing, actually having more of an acute or rib stress fracture becoming something as damaging as an actual fracture due to the tightness of the chest strap, and people actually all those same forces, but now they're restricted because of the class of rowing that they're in. So if it's just arms and shoulders, they're not able, they want to try to get as much length as possible given the restrictions they have with the chest strap, but some people are actually causing a lot of damage with that. So if there are any listeners who are in that kind of population of para rowing, that to really think about that possibility as well as and trying to place the chest strap at an appropriate level. But also, if you're someone who's predisposed to that too, think of all the intrinsic factors you can control, and also try to limit the kind of the volume and intensity changes if you're in that in that situation.
That's awesome. Great actionable advice for everybody to put into use. Thank you so much.
Thank you.
Cool. All right. So let's shift gears a little bit.
Sure.
Do you want to talk about movement as medicine first, or would you like to touch on, kind of physical activity as prevention?
Well, either one, because they're prevention and management. I think kind of the more interesting one that's emerging is the treatment of chronic disease with physical activity. But so we could start there. But let's
do it.
Great. So I don't know where you want me to start, but I guess here in Canada. Well, actually, it's interesting. I did a lot of my medical training overseas in different countries because when I was doing my PhD research, it was really to do with looking at systemic inflammation and noticing a big difference between athletes and sedentary individuals, and that these people doing a lot of exercise would actually have a lower rate of a lot of different inflammatory inflammation related diseases, so such as GI problems, so gastrointestinal problems, rheumatoid arthritis, some types of cancer, asthma, things like that. So it really prompted me to think about the effect of physical activity in terms of as a medicine or as a treatment for chronic disease. And so it prompted my training, I guess, in about 7 or 8 different countries, and looking at how they prescribe exercise, or how different individuals and organizations look at not just healthcare promotion, because I think, especially in North America, we see a lot of really good initiatives in terms of physical activity promotion, without a lot of change in the demographics, or to the extent that we want to see. So a lot of people talk about the rising rates of obesity. In some cases, those have leveled off, but chronic disease is still on the rise, but we're still kind of promoting this, everybody exercise. The tides it's shifting a little bit now, that we're actually looking at, even if someone already has a chronic disease, that either one or more, and because we are talking now about people with multiple chronic diseases, that rate is increasing exponentially. And just looking at in terms of physical activity as treatment for those diseases, and actually seeing a lot of promising results for physical activity being either as an adjunct to therapy or sometimes replacing therapy altogether. So it's an exciting topic for me, but it's a big one. So if there's specific questions, maybe we can start with that.
No, I think that's great. I mean, I think anytime that you can get people moving more, with quality, of course, being inherent, it's a great thing. Unfortunately, at this point in the world, like we tend to sit more than ever,
yes, exactly.
and we're very inactive. And so people, come in and they're kind of, molded to their chair, and they've got, rounded shoulders and rounded thoracic spine and underactive glutes and tight hip flexors and forward head posture and, and stress and anxiety and all those things. And it's amazing. 45 minutes later, after completely different person.
Yeah.
And it's not only from a health standpoint, but it's amazing how much more our productivity increases.
Exactly.
So I'll nobody at work knows I do this, but like I'll get up and like I go to the bathroom and I like go and do like my 1-arm push-ups or like my pistol squats in the bathroom and stuff. And, but I come back and I'm able to like really dial in and focus my work. So I sort of have these like micro mini training sessions, quote unquote, but I'm only doing a couple of reps, but I'm constantly getting up and like walking every hour on the hour. Right.
Yeah.
And, so it's very helpful. So, those were just a couple of thoughts that I had, but yeah, I would love to hear, more about, what your approach in terms of, what you think people should be doing more of, or particular emphasis they should have, whether that's for, certain demographics or, occupations, if there is research or thoughts on that.
Absolutely. So just to add to what you're saying, interesting research that's relatively recently come out in terms of sedentary living, or kind of sitting disease as we coin it now, I suppose, is that idea that even if people are moderately active at other times of the day, if they are sitting for most of the day, it's almost as if they didn't do exercise. It's that bad, right? So, which is kind of depressing. So for the people who think they're, doing great things, wake up in the morning and do an hour run, but then sit literally for 9 to 12 hours doing work. It's actually that effect. So actual sitting, the very act of sitting is an independent risk factor for morbidity and mortality. And so the idea that, as you said, you get up and you do these little exercises and that's fantastic. But as you say, a big reason why it's getting out there more is the issue of productivity. So maybe we can't talk to everybody about how great it is going to be for your health, but from an economic standpoint, for increased productivity, maybe that's a way to reach another certain demographic. What I kind of see in terms of the chronic disease aspect, which I find is really interesting, is really debunking the myths that are out there. So I remember probably reading about this. We wouldn't do it now, but maybe 30 or 40 years ago, people would always suggest bed rest for, if they have an injured back or anything like that, just bed rest for 6 to 12 weeks. And we thought that would be the way to do it. But in fact, we're still kind of prescribing those same types of things for a lot of things, like when people are going through chemotherapy for cancer, when people are rehabilitating post-op, so after surgery, even the kind of the quick fixes that we think about with cardiovascular disease and getting stents. When we look at the research, doing physical activity is actually more protective than stents are for a lot of what we see in terms of cardiac disease. So for a kind of a second heart attack, or a lot of the cardiovascular, the vessel disease around the heart. And we see a lot of things too with even now there's research done looking at cancer fatigue and people going through chemotherapy and everything. And they have barriers that we don't maybe fully appreciate. But that idea of, the nausea and vomiting and the kind of the side effects that go along with cancer treatment, but then looking at the protective effects on quality of life, but also on a lot of these symptoms when patients are physically active, are really revolutionizing the way that we talk to our patients after, those, if they're going through therapy at the time and things like that. I actually find the most exciting areas are looking at things like mental health. So we know that, and we've known for a little while, that physical activity is as effective for mild to moderate depression as Prozac or a lot of the antidepressants. Without those side effects that we think about, so decreased libido, weight gain, things like that we see with a lot of these medications. Also, there was a really good study out of Stanford that looked at the effect of physical activity on just being as good as medicine for things like stroke. So they actually, for people who have already suffered a stroke, again, physical activity is better for the recovery and for further prevention than relying on medication. And so I think those are the kinds of things that really excite me about the field. But on the other hand, it's amazing how few people know about some of these things. And I mean, mental health, of course, we could talk about anxiety, we can talk about PTSD, schizophrenia. There's a whole host of chronic conditions in many aspects of medicine where we're really just discovering the beneficial effects of there's always a place, well, not always a place, but there are places for medication. But the idea that I personally feel as a doctor that it would be negligent of me to not see the evidence that there is on physical activity and then not say something to my patient in terms of the benefits of it when we talk about treatment for their specific chronic disease.
No, for sure. One of my favorite books is Spark.
Yes, exactly.
Yeah, Dr. John Roddy.
Yeah.
And
not sure how to say his name.
yeah, he talks about the relationship between aerobic exercise and the brain.
Yeah,
And
exactly.
it was this really powerful quote in the book, and I'm probably paraphrasing, but I think they looked at basically what happens on a chemical or hormonal level when people take antidepressant drugs versus physical activity, and it's the same thing. Like you get the same sort of quote unquote high, the endorphin rush, without all the negative side effects, like you described, from taking a prescription drug. And it's something that is inherently sort of in all of us because we were born to move.
Exactly. Yeah.
So that's it. That book's great. That and The Brain That Changes Itself by Norman
my
Deutlich.
favorite. Yeah.
Yeah.
Another favorite of mine.
They're great. They're wonderful books. And looking at brain-derived nootropic factor. Is it? Am I saying it right?
Yeah. It's
BDNF.
Yeah.
So that sort of hormonal secretion that happens due to physical activity. And another part that just jumped into my mind from Spark was they did a study of high school athletes running a mile across the country, and their test scores were far and above higher than anybody else in the country. Mm-hmm. And it was because these kids were getting like vigorous physical activity.
Yeah. Yeah, exactly. And so, I mean, from a protective standpoint, that's great, but also from trying to keep our kids absolutely off of antidepressants or even these ADHD medications and things like that just to stay away from the medication. And on the other end of the spectrum, actually looking at seniors and one of the big, I had heard one of our kind of national, he's actually a physician who's trained in Canada and the States and did in charge of a senior care strategy that we're trying to develop here in Canada, mentioned 4 factors in the elderly population that are really kind of taking up the vast majority of our healthcare dollars, but also that are predictive of seniors' decreased quality of life and multi-morbidity and mortality. But he looked at 4 factors, and they were social isolation, fragility, polypharmacy, meaning too many medications, and multi-morbidity, so meaning a lot of chronic disease, so just more than one. And so when I look at through the lens of physical activity, and that's what prompted me to look at specifically at seniors as well, that idea that, wait a second, social isolation, frailty or fragility, and these other, so polypharmacy, getting deprescribing, getting seniors off medication, and really all of these 4 problems with multimorbidity as well can be targeted with physical activity, helping our seniors. Falls are a huge problem in that population, and hip fractures can actually sometimes predict the number of years that a person will live post hip fracture, and the stats aren't great on that. And really to be able to look at physical activity through the entire life spectrum as being something that can be helpful, even when someone is diagnosed with a certain chronic disease. And that's the thing that I like talking to my patients about, because again, just not just thinking about the promotion of physical activity or how many diseases it can prevent, because we all know that. But the idea of once a disease state has already happened, that we haven't all of a sudden lost hope and you're going to be on a medication for life, but actually we can look at either preventing further damage, preventing further heart attacks or whatever, or it could just be a regression of the disease. So looking at the aspects of active lives in that respect.
Absolutely. I just remembered I interviewed an earlier guest this spring, friend of mine, Derek Fitzgerald, and he was the first cancer survivor and heart transplant recipient to finish an Ironman.
Wow, that's amazing.
Yeah. And so what happened is that he was diagnosed with cancer, and the medication they were giving him to treat the cancer actually started to cause heart failure.
Mm-hmm.
And he had to have heart transplant surgery, and so he literally had to like rebuild his body because he had they broke his sternum, and he had an incision basically from his collarbone to below his belly button, below the navel.
Wow.
And so they said that because he's been doing physical activity, he is taking less medication than they thought, and he is surviving a lot longer. The statistically, the trajectory of people that have those types of surgeries and the cancer. So absolutely, physical activity is medicine for sure.
Yeah.
So, is there anything else you want to add before we kind of move into rapid fire?
No, I think that's it. I'm happy to move into the next step.
Okay, cool. All right. So this is the fun part. So this is like, you're kind of off the hot seat, so to speak, in terms of the material, the topics that we're going to cover. And now I get to ask you some questions. I ask all my guests these. Okay. So given your current knowledge and your experience, if you could go back 10 years, what advice would you give yourself?
My former self. I think that, these rapid fire, I'm not going to be rapid fire in answering. I should
it's okay.
set it up. I really think that in terms of my knowledge and experience, I would probably say that in my case, I've done a lot of, as I said, a lot of worldwide experience trying to get a handle on physical activity and that kind of thing. And I think I would probably tell my former self of 10 years ago to really enjoy the ride and not be and to really learn as much as I can. The thing that I've noticed sometimes is that, especially in our culture of medicine, is that people are very mainstream from one thing to another and want to be staff and make a salary right away. And I've kind of had a bit of a pinball career through rowing and medicine. But I think that actually, I would probably tell myself to just enjoy it and not stress about it about the journey, because I really feel having gone through all of that experience has really given me this kind of this perspective on physical activity, and now an increased sense of urgency, but also an increased hopefulness that there are so many other countries and people that are doing great work in this field. And so it's just a matter of using that collective knowledge around the world and making a difference where we are.
Awesome. Yeah, for sure. It's all about the journey, right?
Yeah, exactly. That's what I should have said.
No, that was wonderful. That was wonderful.
Yeah.
All right. What's your favorite strength training exercise?
Oh, you know what? I love cleans. I had this kind of love-hate relationship with cleans, but once you get it, there's really nothing like being able to do cleans in terms of efficiency and whole body workout. That's also very transferable to the boat. So
nice.
It's terrible when you don't have it at the beginning of the season, but once it goes, it's great.
Yeah. Are you doing barbell clean, correct?
Yeah.
Okay. Awesome.
Yeah.
Okay. How has your training changed today compared to 10 years ago?
Training? So in terms of professional training or like rowing training?
Both. So obviously, it's probably not at the same level, but so like I would also say, knowledge based, like how do you approach it sort of day to day, on a micro goal basis and sort of a, macro goal basis.
Okay. So for rowing specifically though, so.
You could do it for rowing and then for your life, kind of where you are right now. Yeah.
Sure. Okay. Well, for rowing, I would say that you're right. I'm not doing the same volume. We would train 3 to 4 times a day, and now I'm training once, maybe twice a day. But my knowledge in terms of, or how I approach it, is actually having had those many years of experience, would be more so to really be able to read my body more. So I've actually been fortunate enough to have actually never had an injury that has taken me off the water.
You're so lucky.
I know. Knock on wood. I'm probably going to wake up tomorrow and all my body parts will just fall apart and, disassemble, or I'll melt or something. But the idea of just reading body and being okay with taking a little bit of time off or changing things up a little bit, I think it would be something. So I look at, and I say I have kind of a plan A, plan B now. So I have the luxury of not having to answer to a coach right now or anything like that. But that idea of, okay, plan A is I'm going to do this high intense workout, but plan B is I might have to modify it and be okay with that. And I think it's the self-confidence of knowing that there's a lot of different ways to get to the same destination. And part of it is just realizing you can do that. So I would probably say the same thing professionally, that there's a lot of different ways to get to that destination, in terms of where you want to be, with, if you want to be an expert in a certain area. And, yeah.
That's awesome. That's great. Okay. So the next question I have, you haven't had an injury, so we don't need to talk about that one. Okay. What's one thing that junior athletes should be doing more of to complement their training and their health?
Okay, so if they're training for rowing and just in overall health, or
and it doesn't even have to
any
be
athletes.
Any junior, so high school athlete. Because I mean, at this point, we're seeing a much higher, sort of across the board, incidence of injury. You know, in baseball, you look at high school athletes having Tommy John surgery, unfortunately, and So what would be some good advice for juniors?
Yeah, so two things I would say is, one, from personal experience that is kind of backed up by research, is the idea to have fun. And so I think a lot of junior athletes in particular get so focused and so intent on trying to reach a certain level early, and not looking at that kind of lifespan approach, or that idea that if you want to have longevity in the sport, to stay to really keep a fun aspect or element to sport, whatever you're doing. And that, I mean, I think back to advice people gave me in terms of, often people will quit a sport if the reason that they joined the sport in the first place is no longer there. So there's usually one kind of specific reason that people join up. For me, for rowing, it was the social aspect because my friends were there. And then if you look at when people quit or drop out, it's usually because of some kind of, the pressure's too much, or they, there's certain other reasons why people get out of sport that aren't necessarily to do with their performance, but it may be the environment or the atmosphere. And so I think if you don't have that protective element of fun, there's something inherent that you love about the sport, you love learning, or you have fun. Then you're probably, if you're just trying to look for an end goal, then, make an Olympic team or make a junior national team, then it's a little bit, I don't know, that I would kind of suggest to athletes, if they want to have fun and have a long career and probably a successful career, to always keep that in mind, to have fun. And the other part I would say that it's also controversial, so it's my opinion only, but it's that idea of not going into early sports specialization. So really trying to be a well-rounded kid. So at least in the early going, junior athletes, to a certain level, later teenage years or whatever. And again, it depends on the sport. So swimming would be totally different, or gymnastics, where you have to specialize quite early in order to do, because also their career span is not as long yet. So, but I think in terms of if you're looking for, I really think especially for little kids, that element of play instead of looking at sports. So signing up your 3-year-old for soccer, or 4-year-old or something like that is okay, maybe if they're having fun, but that idea of competitive sports so early on seems to be predictive of earlier dropout. Now, again, that's me saying this is what I've learned, and it's not my area of expertise, so it's what I've learned from colleagues. So I'm sure there's better ways of doing it, but maybe they can specialize if they have fun. But I just think that sport, it's unfortunate there's so many people in sport that after they are done their Olympic career, that they just hang. So in rowing, it happens all the time. They hang up their oars for good, and then you never see them again. And I really feel that we lose out on alumni or people mentoring younger athletes because of it, and also for people who are just for the enjoyment of the sport. It'd be great to have people still out and participating.
Yeah, no, for sure. And I think that's a great point. I totally agree about early sports specialization. If there's one thing I could go back and change, is I probably have played more sports for longer and then just focused on rowing when I was at college.
Mm-hmm.
because knowing what I know now, it's like, it's funny. I definitely feel like, before I started strength training in the last couple of years, like I almost felt like I walked around kind of lopsided,
Yeah,
from rowing. And so
yeah.
it's not just rowing. I mean, it could be any sport, especially any rotational sport like baseball or golf, where you are sort of becoming very dominant to one side of the body.
Yeah, exactly.
And like you said, you have your entire life to become very focused and serious. So enjoy it more when you're younger.
Mm-hmm.
Yeah. Okay. What's your best tip to improve recovery from a training session?
I would say shut off completely mentally and physically. I think that a great book by a sports psychologist named Terry Orlick, but he talked a lot about, and I can't actually remember the name off the top of my head, but he wrote a couple of books on this. I think it's Embracing Your Potential. There's a gold and a green zone that he talks about, and gold is your performance zone, and green is more the relaxation and recovery. And one thing I took from that book that really helped my own sporting career is that idea of when you're in the gold zone, you are you're performance minded, you're absolutely focused on what you're doing, you give it your all. But as important is that green zone where you shut off mentally, you kind of, you don't kind of keep on ruminating about your performance that day or whatever, but just you have to be as focused to relax and recover as you are in that kind of gold performance zone. So I would just suggest that if you're going to relax, treat it as seriously as you would your performance, and really do things that are going to either grow you as a person or help you develop in other areas of your life, or just really relax and try not to get too focused on the performance world.
I love that. I love that. No, because it's like yin and yang, right? So it's like,
yeah, it is. Yeah,
and it's such a subtle and powerful point you just made there, because we focus so much on the performance or the numbers or the results aspect, but I mean, you can make the argument that recovery is where you get stronger or gain the speed, and that's where all the changes happen, and so by putting as much emphasis and intent behind the recovery aspect and relaxation aspect, you get so much more out of it.
Yeah. And I mean, even just a simple image for the rowers out there. If you think about the catch and the drive and the recovery. So the drive, you want to be as focused, in tune, every element, you put all your force into it. But if you rush the slide on the recovery, if you kind of are as tense on the recovery as you are during the drive and an actual rowing stroke, you'll see that the boat is checking. You'll see that you're actually moving in the wrong direction as you want to go. And you'll get tired a lot faster and won't be able to sustain your performance. So it's also learning as you row to maximize the recovery and just, be very quiet on that recovery, let the boat do the work and that kind of thing. So I kind of transfer that over to life, that the recovery is as important as the drive. And it's just about doing that part really well too.
That's awesome. I've never thought about that until you just said that, but that is beautiful.
Well,
that is beautiful. Okay. If you had to pick one meal, what's your favorite meal?
Oh, breakfast.
Okay. But what would you have?
Oh, what would I have? That could be anything, but no, honestly, it sounds so boring, but I love my, homemade oatmeal with, all the fixings. So you can just drop everything in there. So, a lot of fruit and, nuts and all that kind of stuff. So I love the pancake egg breakfast and stuff too,
Nice.
But I'm just thinking of before training, but, I'm not picky when it comes to breakfast, I think.
Awesome. Okay. Final question. What's one book everyone should read?
Well, you've already mentioned The Brain That Changes Itself, which I absolutely love on so many different levels. So I would say either that one or Spark, the two that you mentioned are pivotal, and they're very important to my own development. But I think it's specifically in thinking about the brain, regardless of physical activity, it's that idea that we don't give ourselves enough credit in terms of how many changes we can make. And if we look at things with a different perspective, how much more positive and how much rehabilitation we can actually undergo. So I think the way that we think about rehabilitation in general is rapidly changing, because we see the brain not as a part of a car, like an engine or something like that, that as soon as it goes, it's gone. But that idea of it's an organ like any muscle that just can be worked on. And I think those are the kind of things that give me a lot of hope that we can view a lot of the diseases and concerns of today in a different light.
Awesome. Very cool. Very cool. Well, this has been an absolute blast. I hope you had fun.
Likewise. Absolutely.
Cool.
It was great.
Good. I'm glad. So just hang on the line. Let me give you a proper goodbye, and we will wrap up this episode.
Perfect. Thank you.
Thanks for tuning in and listening to this episode of the Leo Training Podcast. If you enjoyed this content, please take a moment, head on over to iTunes and drop in a 5-star review. Or please share it on your favorite social media networks such as Twitter, Instagram, or Facebook. It really helps the show to grow, and I appreciate reaching new audiences. Thanks for tuning in and listening, and be sure to tune in next week for a brand new episode.
Thanks for listening to the Leo Training Podcast. Subscribe and get even more expert training tips at www.leotraining.io.